There we go.
Hello, everybody, and welcome today to today's Facebook Live Q&A. Third time's a charm. We have had a few technical difficulties and our guest needed to rush off to have an emergency procedure, but we are here today to talk about diabetes and heart health, and I am joined by Ralph Audehm, Professor Ralph Audehm. But before we start, I would like to acknowledge the traditional owners on the lands where we are all viewing from. I'm in Wurundjeri land, and I would like to pay my respects to elders past, present, and emerging. Ralph, say hello to us, please. I'm so excited to have this chat.
G'day, and look, it's good to be here after my, how shall we say, enforced leave of absence. And you wouldn't believe it. After I came out of hospital, I ended up being a close contact. So after 3 days, I had to isolate for another 6 days.
All right. Well,
7.
I'm thrilled that we are still isolating. We're not actually in the same place, but it's so great to see you, Ralph. Why don't you tell her? I was about to do an introduction, but you know what? Why don't you introduce yourself? Tell us who you are, your connection to diabetes, including how you used to work for a diabetes organisation.
And how I used to be your boss.
And how you used to be my boss. You said 15 years ago, but surely that's not the case. And if that's the case, we must have been infants then. But tell us a little bit.
It may seem like that, but so look, I'm a general practitioner. I've worked in a variety of places around Melbourne, but I suppose my interest in diabetes started with a chap by the name of Matt Cohen. I don't know if you know him, but
yes,
he used to run education sessions for GPs. And of course, when I first graduated, my knowledge of diabetes wasn't that great. Yeah. And I realized I needed to beef it up somehow.
Yes.
After doing that, I started to see a real issue around the care that was being provided. And so I started working what we back then was the divisions of general practice, which gave me a bit more of a broader view of the world and how that, really getting care right is actually can be quite a challenge at times.
Yeah, but it's essential.
Oh, absolutely. And then from there, I got an interest, I got an interest in Diabetes Victoria.
Yes.
And so I worked there for 6 years, I think, or 6 or 5, something like that.
You were the director of community programs, and I was sitting in the community programs team back then.
And mind you, the type 1 team back then was quite small, but gee, they really punched above their weight.
We did, didn't we? It was me and an incredible woman named Louise Brown, who we had our babies within a day of each other, and we were very passionate about type 1 diabetes information and support. But we're not here to talk about that or to reminisce or to walk down memory lane.
Okay.
We can do that, but we're here to talk about diabetes and heart health. We know that there have been recently, very sadly, some high-profile cases of people dying from heart attacks in our community, not people with diabetes, but of course, we do know that if you're living with diabetes, we need to take extra special care of our hearts. And that is what we're here to talk about today, is how we do that, what we need to think about, how we can engage with our healthcare professionals about what it is that we need to do, any medications we might want to think about, and lots of different things as well. We already have a couple of questions in here, but let's start. I'm going to start with a question, basic question. What is the connection between living with diabetes and cardiovascular disease?
Oh, big question. I hope you got a whole day.
No, okay. You've got 30 seconds, Ralph.
Okay, 30 seconds, right. Basically, let's talk about 3 major types of diabetes, 1, 2, and gestational.
Yep.
Type 2, the way it develops, the underlying mechanism is really bad for the heart.
Right.
So type 2 diabetes, you can almost talk about it as being, in many ways, a cardiovascular disease, right, where the sugar is, or the glucose is just part of the equation. But really, treating the risk factors around heart disease is probably the most important if we want to make great outcomes.
Okay.
Recent research has shown that women who've had gestational diabetes, it puts them at a higher risk of getting type 2 later on, but they also have a much higher risk of heart disease later on. And so they now, this is fairly recent, so we need to look at them and manage their cardiovascular risk much more aggressively than we have in the past.
Okay.
Then you have type 1. Now,
Mm,
type 1 we used to think wasn't really a cardiovascular risk because you didn't have the insulin resistance and all that sort of underlying cause.
sure.
But we now know that, in fact, heart disease is very much overrepresented within the type 1 population.
Mhm.
Certainly in people who are diagnosed as children, their risk is much, much higher.
Okay.
But certainly, the associations with renal disease is
Yes.
also very strong as well. So we now really need to get GPs to reevaluate that cardiovascular risk for type 1s. Now, I know most people with type 1, well, I think, this is me thinking, making generalizations, that most people with type 1 would have an endocrinologist who would be around this. A lot of GPs may not be aware of that association with type 1 and heart disease. We're not quite sure of the underlying mechanism, but we think it may be pro-inflammatory. It may be to do with the glycosylation, but yeah, it exists and it's there.
Okay, so let's talk about what sort of things that, as a person with diabetes, every time I walk into seeing a GP or my endocrinologist, what are the conversations that I should be having about having my, thinking about my heart? And I'm going to preface this by saying, every year I go and get my eyes screened because I know this was drummed into me at diagnosis. You need to look after your eyes. The best way we can do that is regular screening. Regular screening means early diagnosis, means early treatment, means best outcomes. Get your eyes checked. I am absolutely meticulous about that. The same goes with making sure that I have my kidney function checked every year, and my endocrinologist makes sure that that happens every year, and we do that, and we're very conscious about that. No one actually ever said to me when I was diagnosed, oh, and these are the things you need to do around screening to look after your heart. So what are those things, and then who should we talk to about making sure that that's happening?
It's a massive question, and it's a massive question because a lot of the research has pointed that what we really need to be doing is managing risk.
Yes.
So, doing routine, stress tests and angiograms, in fact, doesn't actually make that much difference and causes a lot of complications, but it's actually managing the risk. And there was a wonderful trial where they actually looked at people who had a stent versus aggressive management of their risk factors. At the end of the day, there was no difference. So if you don't have an acute issue, it's like managing the risk is the key. So then you've got to start thinking, well, what are the things that are putting me at risk? So certainly duration of diabetes, and that's really important for type 1s because up to now, we really haven't grappled that one. Certainly things like blood pressure. Blood pressure feeds in and is a high risk factor. Your cholesterol.
Yep.
And then specifically around diabetes, if you have protein or microalbuminuria, that puts you at a high risk.
Talk about that. So what do you mean about that? Is that, which check do we have?
So you have the annual spot urine check looking for microalbuminuria?
Yes, so it's a urine check. Yep.
Okay, so if we see protein and it's confirmed, we would treat you as a high risk heart person.
Okay. All right.
And then renal impairment. So if your renal function drops off, your EGFR or your creatinine is going up, that also puts you at much higher risk. Then, of course, you've got things like smoking, family history, and then it sort of starts to, broaden.
How are those checks that you just mentioned? Is that a blood test or is that also part of a urine?
What, the family history? No, I
asked about before that. No. Family history, we get.
Yeah. So your lipids and your cholesterol, we would suggest that all people with diabetes should have it done annually. I think that's really important. The urine, the actual filtering of the kidney, that's also a blood test. And often we do the two together with your A1C.
Okay, good.
We do the A1C a little bit more often than we do the others. But those three things are really critical. We do say that you should have your blood pressure checked at every visit, but look, at least if you've had it twice in a year, I think that's, well enough. And then, asking specifically about, do people get chest pains when they're exercising? Are they more short of breath than what they should be? Has there been a change? Because the hallmark of heart disease is really chest pain on exertion or shortness of breath when you're exercising. Now, it doesn't always, there are people who slip through the cracks, but we need to ask that, because if you get chest pains with exercise, that is heart disease till proven otherwise.
Right. Okay. All right. So these are all really important points, I think, for people to be noting down. Now, one of the things that I always talk to people about is, certainly with HbA1c, and that's often the one that we have this conversation about, is make sure you know what your result is, write it down, and write it down, year to year, or however frequently, or, every 3 months or every 6 months, however frequently you're having it, so that you yourself can keep a record of what that looks like. Should we be doing that with other things as well? Is that a good idea, with your blood pressure and with the cholesterol and with other things as well?
Look, I think people with diabetes in many ways are experts in their own healthcare, and
I agree.
The activated, interested person who tracks all of that actually will do better, because they show an interest, and I love it. I mean, I know doctors hate it, but I love it when people come in with papers from the internet and say, well, what about this? I think it's absolutely brilliant.
Yes.
But yes,
everyone should. Conversation.
Yes, everyone should know their numbers. And, the numbers you need to know, as you say, is A1C. You need to know your blood pressure. You need to know your lipids. You need to know whether your kidneys are doing really, really well. You need to know your weight. And then, of course, family history, most people will be aware of. And, then, even tracking things like, how much exercise people are doing, how their weight's going. And I must admit, I do love wearable technology, because I think it's a great way of feedback to people in terms of making change.
Yep. Fantastic.
Now, on top of that, if you were really interested, there are heart risk calculators. So this is where you put in all the things.
Yes.
And it tells you what your risk is.
Fantastic. So now, there are risk calculators all over the place. But in fact, there are diabetes risk calculators for people who don't have diabetes. So can you explain what it is? Because a calculator sounds like it's all about maths. And there are a lot of people, I mean, if you live with diabetes, you become an absolute wizard often at maths, especially if you're calculating carbs and all of that sort of stuff. But what is it? Is it a calculator that you pick up? What can you explain what these calculators are and what they mean?
So you know how we were talking about things that we were measuring?
Yes.
If you put all those things together, with your age, you can actually work out in Australia, it's a 5-year risk of having a heart attack or stroke.
Yep.
A lot of the overseas calculators use a 10-year risk.
Okay.
But a lot of the calculators are fairly, how should we say, opaque when it comes to diabetes. So
right, okay.
I know the Australian risk calculator is currently undergoing a rework, but at the moment, all you say is diabetes, yes or no.
Yes.
Whereas I think, I did share with you, I think once an overseas calculator that actually separates type 1 and type 2.
But it doesn't give you the option to put in duration of diabetes. No. I would expect that that's important. So can we maybe just mention one, and then we will later on, we will make sure that we put this in the comments so that people can go back in and do it. Which one
so
did I do?
So the cvdcheck.org.au is
Say it again.
cvdcheck.org.au. That's the National Heart Foundation Heart Risk Calculator.
Yep.
And, it doesn't have a lot of things like weight or family history, but it is actually undergoing review, and a new one will be released at the end of this year, which we're all really excited about.
Yeah, good.
And then there are a variety of extended calculators that people can search for. And look, the one I often use is the Q risk, but of course it's specifically for the English population. So you have to sort of make a couple of, how should we say, leaps of faith when you're using it.
So I did that the other day, because when we were chatting while we were waiting to
get
on Tuesday, but then Facebook wasn't playing nice, so we couldn't do that. We were killing a bit of time, and I did that, and it came up. Can you remember what it said for me? I think it was like 6.3%.
Yes.
So what does that mean? Does that mean that? Yeah, explain it to me.
So 100 clones of Renza, 100 people just like you, over 5 years, 6 people would have a heart attack or stroke. The interventions that we do, that for each intervention, whether it be, a cholesterol lowering tablet, a blood pressure tablet, whatever, would lower that risk by 1/3.
Okay.
So, you know, if I treated you with a statin, your risk would go from 6 down to 4. So I'd have to treat 100 people for 5 years to prevent 2 events.
Okay.
So we would call that low risk, because the risk benefit ratio, but risk is such a personal thing. You may say, doctor, 6% chance of having a heart attack in 5 years, that's too much.
Yeah, I don't like those odds.
Yes. And remember, so in that case, you know, it is really about a conversation about where you're comfortable with that risk or not, and whether you want to do something about it. But certainly under 10%, we wouldn't recommend any specific treatments.
Oh, okay. Yep.
But remember, with that duration of type 1s and people who've had type 1 diabetes when they were a child, they're at a risk, and the calculators often don't capture them because
it's a bit blunt, isn't it?
Yeah, and also their risk starts at a much early age before a lot of these calculators come on board. So,
right, okay.
And this is where I think it's very important to, you know, ask the question of your endocrinologist.
Yeah.
You know, what's my risk? When do I need to start thinking about going on something like a statin?
Yep. Okay, we've got some questions coming in, and hey, how's this for a current question? Should COVID now be added to the risk calculator? You know what? Let's just talk about all risk calculators, because we know that there is some early research to suggest that people who have got COVID have an increased risk of getting type 2 diabetes. So let's just talk about that. Should COVID now be added as a risk?
No.
What do you think? No.
No, look, the way I look on this is that people who have acute illnesses,
yes,
especially severe illnesses, they all put people at risk of having an event because it's a stress on the body.
Yep.
And if something's going to happen, it's going to happen when you're under stress.
Yes.
So in its own right, it may be a precipitating factor, but not a risk.
Okay. All right. Good.
One thing, look, I do want to get one message across that's really clear. People often don't know their risk. Most people, at least 40% of people turning up to hospital with a heart attack are at high risk, but are on no treatment.
Say that again, what percentage?
So about 40% of people turning to a hospital with a heart problem are at high risk, but have never received treatment.
Interesting. Okay.
So this is why I think it's really important that all people, type 1, type 2, gestational, and then everyone else, know what their risk is and actually get treatment if you are at high risk. Absolutely.
You know, I love how we're talking about this. We're talking about risk reduction, and that is, I think, it's always my preferred terminology rather than prevention, because we can't guarantee or promise that do this and we're going to prevent this happening, but there is so much we can do about reducing our risk. And I love the idea of putting things back in the power, you know, back in our hands and in our control, because there's so much about diabetes that isn't in our control, like getting it, for example. So, okay, we've got a really good question here, and somebody's just sent it to me on my phone, so please excuse me reading this, but okay, what can I do now in my mid-20s to reduce heart problems in the future? So I'm not sure what sort of type of diabetes this person has. T is how they've signed it.
Yep.
But,
look, our usual sort of generic advice to everyone is regular exercise and at least 2 to 3 weeks, 2 to 3 days per week with a bit of huff and puff.
Okay.
So, you know, where you're increasing your heart rate and you're getting a little bit of, you know, puffing going. A healthy diet. And if you're going to pick a healthy diet, you know, the best evidence is around the Mediterranean diet. If you have a tendency towards blood pressure, there is a thing called the DASH diet, which also has evidence around it. That's like a Mediterranean diet, but low salt. Okay. Yep. So they work really well. So diet, exercise, stress reduction. So we know, but this is important. People, you know, with diabetes, we know it has an impact.
Oh my goodness, yes.
Well, yeah, you know better than me. So this is important. So having time out, you know, doing some meditation or doing things that you really enjoy, switching off. I mean, you know, I'd say love to have a holiday from diabetes, but I don't know if I can actually give you that. But so stress reduction, smoking, really bad.
Okay,
so if people smoke, we need to help them, you know, stop. And there's lots of ways we can do that. And I think quitline must be, what, 50, 40 years old now?
I think so, yeah.
But
that's a really good conversation to have with your health professionals. And, I think that I really like the way we're talking about this. It's not a judgmental conversation. People are smokers. People are ready to quit and they need support rather than being wrapped over the knuckles and told off for what they've done in the past. Let's talk about what happens from this point forward. Yeah. And I think
the waving of the finger doesn't work.
I
think we've worked that out now.
Yeah, and can I tell you, people with diabetes have been saying that forever and ever and ever. But
thanks get your act together, Renza. Come on.
Thanks for catching up there, Dr. Ralph. Now, let's go back to blood pressure for a minute, because we know that with HbA1cs, we're always told keep it below whatever number. Now, individualized targets are really, really important.
Yep.
So we're going to talk a little bit about blood pressure goals, but I want to preface this with a comment saying, of course, this will be different for everybody, and you should have a conversation with your healthcare professionals about setting goals that work for you. But if you were to say, this is what we should be aiming to keep our blood pressure at or below or between, what would that be?
It's interesting. When I first went through medicine, there was some evidence that, lower the better.
Yeah.
And so there used to be this concept of just keep adding tablets until people got a bit dizzy and then just take it back a little bit. But no, so for most people, with diabetes, we'd be aiming for 130 on 80 or less if we can get people there.
Yes.
And, certainly there are certain medications that we know that we use in preference for people with diabetes. These are the ACE inhibitors and the ARBs. But where I really like, you guys are great. You know how to monitor your blood glucose and all those sort of things. What I'd love to do is see you all actually self-monitoring your blood pressure as well.
Okay.
Because what we do know, again, if people are involved in actually monitoring their own system, they become really good at telling you what's going on. And, rather than coming up to a doctor, like you're going to the principal, having your blood pressure taken, it's high again today. You look, maybe we need to put you on medication. The scenario goes the other way. Doctor, I've been checking my blood pressure and they're all above where I should be. Do you think I need medication?
Right.
Now,
okay. Yes.
the dynamic is so different.
Yeah.
And I'd say, look, I agree with you. These are the tablets that we would suggest. What do you think?
Yep.
It's a completely different conversation than me saying, oh, your blood pressure is too high. You need to be on tablets. Let's go.
Yeah. Okay. All right. And so is that a matter of, and I'm going to say this with great reluctance to even ask this, because, I monitor my glucose. I've got a CGM. There's so much data in my life. Should I really be doing my own home blood pressure checks? Well,
again,
I do.
Everyone's different. Some people like to do it, some people don't.
Okay.
I mean, you can still go to your GP and have your blood pressure checked.
Yes.
You can still have 24-hour blood pressure things if you want to do it once a year or whatever. Pharmacists will also do your blood pressure check as well.
Okay.
There is a thing called white coat hypertension. This is where people, they're going into the principal's office, so their blood pressure goes up. And so sometimes
we get told off by our doctors and we're scared about that.
Oh, look, I hope that's
not my doctors. I mean, I should just be very clear and say not my doctors, but we hear that. There is a concern that there will be a bit of, what are you doing? What have you done wrong? And that makes us a little bit anxious at times.
For sure. And this is where, the home blood pressure reading, because I tell people to do it in the morning, first thing before they get out of bed, last thing at night. It's when they're most relaxed. It's, it gives a nice, good reading. If you do it during the day and it's been a bit of a challenging day, their blood pressure will be up. Absolutely. Sure. So you can't really take that. But it is important. It is important to get the blood pressure down. And like I say, lifestyle, the exercise, the healthy eating is really important to keep that, at target.
So when you just said that, either first thing in the morning or at night, is it important to do it at the same time every time that you're checking it? Is that a good way to sort of get that rhythm?
I often tell my patients, depends where they are. If it's someone who's been relatively high,
yeah,
and I want to know, I'll often get them to do morning and night for 5 days in a row.
Yeah, okay.
And that gives me a great sense. But for people who are at target, I might say to them, look, 3 days in a month, check it.
Okay.
Or it might be once a week.
Yep.
But if you ever feel unwell or dizzy, which you do with your glucose, check your blood pressure as well.
Yes. Okay. All right. Now, can I ask you something? Because somebody mentioned this to me the other day when I told them that I was having this conversation. They were told that when you're checking your own blood pressure on a home blood pressure machine, do it twice. Do one reading and then do the next reading. Why? What's going on here?
My patients will always say that I always tell them the first reading is always high, just because I've put the actual cuff on.
Right, okay.
And then after that first, what's happening? You tend to relax a little bit.
Right, okay.
And so the second one drops. And I often tell people to do a third one.
Right,
and it'll often drop down a little bit even further. But it is actually important that you get taught how to do it properly. And there are some great resources on the Heart Foundation website about how to sit, how to position the arm, how to position the cuff.
Okay, good. All right, we're going to share all of these links, everybody. So we will make sure that we go back and watch this, and anything that we've spoken about, we'll make sure that we share these links. What about heart rate? Is that something else that we should be monitoring? I've got a watch that does that for me now. Should I be doing that? Because I can just press a button.
Yeah, look, interesting. So certainly with some of the new Apple watches that they've actually been approved for monitoring for things like irregular heartbeats, it's a fantastic thing. So when people have palpitation or the heart rate seems to be fast, they can press the button and we can see whether people actually have AF or not. Now, atrial fibrillation is an irregular heartbeat. The reason why we're so interested is as people get older, it's a major contribution to stroke. And yet there's treatments that we can do that make a big difference. So monitoring heart rate is a good thing. Now, for someone as young as you.
Oh, this is why you've always been one of my favorite people, Ralph.
Yeah, look,
not so young anymore, but go on, yes.
People can use it, if they want to track how, their fitness overall is, but of course it's a relative thing, not an absolute thing.
Okay.
I'm not that
all right
interested in the heart rate, but I am in the blood pressure.
Okay, so asking the same question that I asked about blood pressure is, what sort of range should we be aiming for? It's a bit more difficult when we're talking about heart rate.
I mean, often we used to say lower the better, but there are some people who have a low pulse no matter what they're at. So I think it's more a check on how you're going. So look, let's say you started off with 80, you've then gone on to an exercise program, and then over the course of 3 to 4 months, your resting pulse has gone from 85 down to 72. You would think, oh, well, that's actually a good sign. That there's some sort of improvement there. Can I point to any outcomes associated with that? Probably not. Okay. We would say that your normal pulse is between 60 and 100. Yes. Now, this is really interesting. Someone with type 1 who may be prone to getting hyperthyroidism, often that will increase your heart rate.
Right. So what's hyperthyroid?
That's an overactive thyroid.
And of course,
which means that in fact, too much thyroid hormone going around your system, your pulse starts to go up, you feel hot, you feel sweaty, hot flushes. And so if you see a sudden change like that, you could say, oh, maybe I need to get my thyroid checked.
So can I just say they're the symptoms for some people of having a having hypoglycemia.
Yeah, but this would be persistent.
Right, okay.
Because your hyperthyroidism would be all the time, whereas your hypo, Well, hopefully you'll treat it straight away.
Hopefully. But also symptoms perhaps of menopause and perimenopause.
Absolutely. Look, it's really hard, sometimes sorting out when people have lots of intersecting things at once. So, yeah.
So can I just say this is actually a really important conversation around, this is why having a great GP is really important, because if you've got a GP who's just dismissing everything as it's just menopause or it's just diabetes, it actually might be something else. That without any investigations, don't just accept that that's the answer. Ask more questions.
I hate that word just.
Oh,
Just
so do I.
menopause.
Yes, I agree. Yeah.
And, there are so many things that happen around menopause that are so important to look at.
Yeah.
It's just diabetes, isn't it?
Just diabetes. It's just diabetes. But we get that all the time, and I remember, like, it's a regular conversation amongst people with diabetes is, I've gone in with a sore arm and it's like, it's your diabetes. It's like, it's not my diabetes. That happened last year. I had tennis elbows. There's an increased risk in diabetes. Great, increased risk, fine, but this isn't because of diabetes. So let's work out what I
don't
need.
get me started on the stats around COVID. They had diabetes. Okay. Well, in fact, they would still be here if it wasn't for the COVID. So how dare you say it's diabetes?
Thank you, Ralph.
God.
I appreciate you saying that. Okay, here's a great question. I'm so glad that we have had this question asked. What do you think of a low-carb diet? I recently went into it last November and so far amazing. I monitor my blood sugar levels, my BP and weight. Now, I'm going to preface this, as I often do with different things, saying there is no one diet to treat diabetes. Working out what works for you, what is sustainable, what is affordable, what is enjoyable is super, super important. And for a lot of people with diabetes, it is a low carb diet. So there's no judgment here at all. This is a really valid question. So I'm going to ask you, Ralph, what do you think of a low carb diet?
Oh, I'm not on, no. Low carb diets, again, look, I think you answered the question. Everyone's different, and some people really thrive on a low carb diet. Certainly in people with type 2 who are on insulin, or even without insulin, often you can see a fairly dramatic improvement in their sugars when they go on a low carb diet. Certainly you've got to be a little bit more careful with type 1. So you've got to know a little bit about your insulin use and how you're going to correct for it, because when you start cutting out your carbs, you're going to have to reduce your insulin quite significantly. And I've had some people absolutely hate it.
Yep.
And I think you're right. Some people enjoy it, some people don't.
Yeah.
It's interesting that there is the other side of this, is that for people with type 2, there is a really big push for putting people on these very low calorie diets when they're newly diagnosed.
Yes.
Because there was a study done in England showing that a lot of people, I call it a bit of a commando diet, but again, some people can do it and do it well.
It's tough, yeah.
But you can actually put people with type 2 into remission.
Yes.
Unfortunately, I can't say that about type 1.
Sadly, no. But that certainly is something, and I know that actually we have done some of these Q&As. We did one last year on low carb diets, and I think a couple actually. Diabetes Australia does have a low
position statement on it,
and a type 2 diabetes remission position statement as well. We're going to share all these links so you will be able to find them.
So we shouldn't forget about our friendly dietitian, because there are some dietitians who are really good either at carb counting and also talking about low carb diets. And if you're on a pump, and depending on how au fait you are, involving a diabetes educator around changing the settings on your pump to what you've done, I think it's really important.
Absolutely.
Although these days it's all automated, isn't it?
Not for everybody, but for a lot of people, yes. And I would also say there are some really great peer networks, and often speaking with other people with diabetes is a really useful, obviously not for medical advice, but for tips and tricks and just, some really practical day-to-day information about different diets is really, really important. Okay, we've got a question. And I didn't say this at the beginning, but clearly I didn't need to. I was just going to say, please do ask questions. We have Ralphie probably for another 10 minutes. Otherwise, I'm just going to keep firing questions at him, but we've got some great ones coming in. My endocrinologist is sending me for a CT for calcium score test. I don't like score tests. That sounds like can you study for it? Anyway, should I be worried? What's a calcium score test first, and why would this person be having it done?
Look, it's a great question, and it's certainly technology that's emerging within the Australian context.
Okay.
And it's another way of assessing risk.
Right. Okay.
So, and the studies to date have shown that it performs as good or even a little bit better than our traditional risk calculators.
Okay. Right.
And what it's doing, it's a low dose CT scan of your coronary arteries. So your coronary arteries are the arteries that go around the heart. And what it's looking for is how much calcium is in those arteries. Now, when you develop, atherosclerosis or hardening of the arteries, initially there's what we call soft plaque, which is, cholesterol and lipids all in it. But with time, the inflammation at the body calcifies it. And so when you do a CT calcium score, if it's high, it says, well, you must have had atherosclerosis for a long time to see that amount of calcium.
Oh, okay.
And so what they do, they add it up, and it will actually risk stratify people into, if you've got no calcium, you say, well, your risk is really, really low. If you've got stacks of calcium, we may in fact send you directly to a cardiologist and say, what do you think? But it's a risk calculator. It doesn't actually look at the quality of the arteries. And you've got to be a little bit careful. So you have to have had the atherosclerosis for long enough for calcium to work. So, and I'm not sure about the data on people with diabetes, but certainly if you were doing a calcium score in someone under 40 who doesn't have diabetes, it may be a bit erroneous because they haven't really had the time to calcify all their arteries.
Right, okay.
So you've just got to be a little bit careful about that. And certainly that's a discussion I'd have with your endo.
How do you, so what is this? It's a CT, is it?
It's a CT scan. So
what does that mean? Can you explain
you lie on a bed, they put you to this great big donut. They take so it's low dose. So it's much, much smaller dose because calcium's easy to see on x-rays. And basically they then see all the calcium in the arteries around the heart. They put little circles around it and they add up the total score. And then from that, they give you a risk. And it'll be no risk, low, or not low risk, but low risk, high risk, and then in between, depending on your age.
Okay, very good. Now, you mentioned cardiologist earlier on. I wanted to ask you, at what point should a person with diabetes add a cardiologist to our often shopping list length of healthcare professionals?
Okay, so I mean, again, that's all about how long's a piece of string.
Yeah, I know.
So anyone who has symptoms. So if you've got chest pains, exertional chest pains, or exertional shortness of breath, heart murmurs, you're going to get a cardiologist involved straight away.
Yes. Then
the question becomes, and sometimes you find this, you do a risk score on someone and you think, oh, that's reasonably high. And then you ask a little bit more probing questions, like when you go upstairs, what do you like at the top? And I had one guy recently, again, didn't have diabetes, but said, oh, no symptoms whatsoever. Now he came back with a calcium score that was very high.
Okay.
When I asked him, he said, oh, well, when I do get to the top of stairs, I am really tired. I am really short of breath. Right, and I've gone, set him off to a cardiologist, went straight for an angiogram, and he had a really, really tight blockage. So again, the symptoms is really the key here, because if you have no symptoms, aggressive management with all our medication is what people need. If you have symptoms, you need to get on board with a cardiologist.
Okay. All right. So, Ralph, I'm hearing, it seems to be like the recurring call of diabetes. Early diagnosis, early treatment, and correct treatment, best outcomes.
Yes. The problem, of course, is that we're treating, when it comes to heart disease, we're treating risks, not disease.
Yeah. Okay.
And so people say, well, I feel well. Why do I have to take these 2 tablets?
Yeah, to keep you feeling well.
Yes.
Yeah. Okay.
But if you have pain in the knee and you take a tablet, the pain goes away.
Yeah.
It's easy to keep. But we're saying take this for future benefit.
Yeah. Okay.
It makes it very hard.
Yeah, I get it. But I'm really all about protective stuff. So I want to know what I can do to protect my heart, because I figure that that's something I can control. Great question here. Men are 4 times more likely to die of heart attack before the age of 65 than women. Somebody's just put that in. We probably should fact check that, but that's what they've said. Are there any male specific measures that can be explored to reduce men's risk of cardiovascular disease?
Okay, so first of all, in people with diabetes, the rates of heart disease are the same, both men and women.
Okay, there we go.
So that's that. It's a great leveler, so to speak. But men. So again, more likely to be a smoker. In terms of specifically maleness, actually, I'm a male. I can say whatever I like, can't I? But
don't generalize and be stigmatizing.
Yeah. But look, I think. Well, the story used to be that we used to think that estrogen was quite protective for women, prior to menopause, and then when women went through the menopause, their risk went up to where men were. We're starting to realize that, in fact, there's an unconscious bias against women and heart disease.
Yeah. And everything else, but yes.
Yeah, no. And you're going to see a lot of discussion around this from the Heart Foundation, because women tend to not get treated as aggressively. They don't tend to get as many angiograms, nor as many stents. And we're not quite sure why. And so they're doing a bit of work around this. But so, yes, I think men, if I was going to generalize, if you didn't want me to do, men are far less likely to rock up to a general practitioner and ask for a health check. They're sometimes, when they do come in, it may be for things like a certificate, and maybe at that point in time an opportunity is missed to do a heart health check, or organize some of the tests that they should have. Sometimes when we do give men those sort of things, because they don't have that long-term relationship, they often don't come back for a long time, and then they'll say, "Oops, I forgot."
Yep.
But they're all generalizations. But really, in this day and age, every person should know what their risk is in their 40s or 50s, and then do something about it.
Yeah.
And if we do that, that should bring that gap right down.
Yeah, absolutely. Okay, Ralph, I'm going to ask you because I think it's important that we talk about this before we go. Talk about flu jabs. Who should be getting them and when?
Everyone.
Yes.
Oh, well, as long as you're 6 months or older,
yes,
everyone should have a flu shot. And in fact, there is great evidence that those who have, funny, you are aware that flu shots protect you against heart disease?
Yes, that's why I'm asking. But do you want to tell everyone about that?
Yes. So what they found was that, in fact, those people who have a flu shot far less likely to end up in hospital with a heart attack.
Interesting.
Now, I think this goes back to what I was saying before. Whether it be COVID, whether it be the flu, whether it be any other major illness that you get.
Yes.
It puts you under stress. And if there's a stress going on, that's the time when things are going to happen. So having a flu shot, no brainer. It really does either prevent or reduce your risk of getting the flu shot. Getting flu, and the illness will be not as severe.
Yes. Yep.
And so hence the protection. And when you think of how cheap it is, it's an absolute no-brainer that everyone with diabetes should have a flu shot.
Everybody with diabetes is eligible for a flu shot.
And they are too, yes.
So go and speak with your GP about it. And now, right, it is flu shot season now, yes?
So in our clinic, we've already had 4 cases of influenza A.
Right.
So it's starting out there. So I think getting it now as soon as you can.
Yes.
And especially if you're going to travel, because, when you're traveling, you're in crowded places, really important to be protected.
Yes, good. And while we're talking vaccinations, because Diabetes Australia we are very, very firm believers in vaccinations. The COVID winter booster is available to certain cohorts, people 65 and over, residents of aged or disability care facilities, people aged 16 and over who are living with severe immunocompromise. Is that right? And also First Nations people aged 50 years and older, you can have yours now, provided it's been 4 months since your last jab. I'm sure that you would very much be encouraging people to go and get their jab straight away.
Absolutely. Again, it's interesting, this whole COVID debate. If we go back, I mean, I love narratives.
Yeah.
And in my life, I've had, the privilege of looking after people who lived through the previous polio epidemic.
Yeah.
Many people may not realize that, back in the 50s, there was a polio epidemic. They had to shut down schools. They had to isolate people.
Mm-hmm.
They had to do mass vaccination. And of course, now we live basically free of polio because of what they've done. But I had to look after people who had to live with the sequela of polio.
Yeah.
Now, people, if they would have interviewed those people and really got it out there, how important, prevention of these sorts of illnesses, I think the narrative would have been so different. But I think we forget.
I think that you said it, though, in the beginning of that, you said people might not remember. And I think that's part of the issue. I mean, I certainly have never met anybody living with polio, but my parents can talk about examples of, people at school. So,
and we got through it as a nation.
Yes.
We pulled together, and it worked.
I know. Ralph, thank you so much. Before we go, just a couple of things that I want to mention, and that is that the NDSS helpline will be operating over the Easter period, and next week we will have a post up on all of our socials and on our website about the hours that we are operating that. Also, if you have type 2 diabetes, you might like to have a look at our type 2 heart campaign, which is take diabetes to heart.com.au. Again, we're going to share all of this if we haven't already, so you will be able to just simply click on a link for that. We've spoken about important things such as flu shots and boosters. I think I've covered everything I need to, so I'm going to throw it to you, Ralph, to see if there's anything that you want to mention to wrap us up.
Look, at the end of the day, know your risk.
Yes.
If you know your risk, you'll know what to do. And please be really positive about asking it. Don't wait. Don't be passive.
Yeah,
I know you never will be, Renza, but yeah.
I won't be, but I know that it is hard. And if you are not happy with the answer, if you feel that your concerns are being dismissed, keep asking. I think that's really important. Find a doctor like Dr. Ralph who will be more than receptive and have conversations with you. Ralph, it is always such a delight to speak with you. Thank you so much for coming on to this Q&A. I have a feeling this isn't going to be the last one that we do with you. And
let me say, so proud that a little worker working for me in Diabetes Victoria has now done so well.
Oh, gee. So lovely. All right. Thanks to everybody. Really enjoyed this chat. It's been terrific. Of course, it will be available on our Facebook page forevermore, so you can share it with anybody who has missed it. It's also on our YouTube. We will share it on our Instagram. We will share it on our Twitter. You cannot avoid it. But please do share it with anybody who you think might find this information important to them or relevant or interesting, because I think it was a very interesting chat. Thank you so much. And we will be back in a couple of weeks with another one of these Q&As. Keep an eye on our Facebook page for details. And Liam, I think we can end the broadcast now. Thank you.
Thank you. Thanks, Renza.
Bye.